So we'll move on to another basic topic, peripheral iridotomy. So after von Graefe introduced peripheral iridectomy or incisional iridectomy to treat congestive glaucoma, that drew the interest of many ophthalmologists around to look at non-invasive techniques to do the same thing, which is creating a hole in the peripheral iris. So they used many lasers to do that. And then in 1970s, they've started using the argon laser. And then since then, it's been largely replaced with the ND-YAG laser more recently. This all avoided a trip to the OR. It also minimized post-op complications and improved post-op recovery. The main effect of a peripheral iridotomy is to eliminate or prevent pupillary block, which is the commonest cause of primary angle closure. And what pupillary block is an abnormal contact between the iris and the lens, causing or impeding the flow of aqueous from the posterior chamber to the anterior chamber, causing, so the pressure or the aqueous that's trapped in the posterior chamber causes a billowing forward of the iris, and that occludes the trabecular meshwork. Whereas with a PI, a peripheral iridotomy, what you're doing is you're bypassing that impediment of flow, thereby equalizing the pressure between anterior chamber and posterior chamber, causing a flattening of the iris and hopefully opening of the angle. So the indications of a PI would be classically to abort an attack of acute primary angle closure glaucoma. You can use it in any form of the angle closure glaucomas, whether it's primary angle closure suspects, those who have occludable angles, classified as having 180 degrees or more of iridotrabecular contact, or inability to visualize posterior TM. Primary angle closure are patients with occludable angles and high pressure or peripheral anterior synechia, as well as PACG, which are all of the above, plus glaucomatous optic neuropathy. You also would do it if you have a complete or partial closure of the previous iridotomy. You would do a revision. And its benefits in pigment dispersion syndrome is not really proven in long-term studies. However, theoretically, you would relieve a reverse pupillary block and probably inhibit further liberation of pigment. Any sort of entity that has an element of pupil block, like aqueous misdirection, would benefit from an LPI as well. Secondary angle closures with absolute pupillary block, so not the relative pupillary block that we spoke earlier in primary angle closure, but an absolute pupillary block where there's an actual anatomical obstruction to the aqueous outflow, like lens-induced glaucoma such as phacomorphic, microspherophakia, ectopia lentis. In uveitis, when you've got 360 degrees posterior synechia that inhibit the flow of aqueous, that can cause iris bombé and pupillary block. If you're not sure about whether the angle is really occludable or not, you're 50-50 about it, then probably taking risk factors into consideration and maybe performing a provocative test will be helpful. It also is helpful in confirmation of non-pupillary block primary angle closure mechanisms where you do an LPI and the angle still remains narrow or occludable, such as plateau iris syndrome. You use it in prophylaxis for a fellow eye of acute primary angle closure glaucoma, or a silicone oil-filled eye, or an eye with an ACIOL. You will not perform a peripheral iridotomy in cases with secondary angle closures without pupil block, and in anyone that are unable to cooperate or the procedure is not possible because of visualization or issues or risk of complications. So the technique, like any other procedure you would do, you would take an informed consent after explaining the risks, benefits, and alternatives of the procedure. You would constrict the pupil with 1% pilocarpine, or even up to 3% or 4% pilocarpine half an hour before the procedure in order to really thin that iris peripherally to be able to penetrate through easily. Another way of pupillary constriction is to use the consensual pupillary reflex during the exam, during the procedure, and that would constrict the pupil as well without pharmacologically constricting the pupil. You would blunt IOP spikes by instilling an alpha agonist, either apraclonidine 1% or brimonidine, half an hour before and as well right after the procedure. An alternative to that would be using Diamox PO 500 milligrams if there are no contraindications. Adequate anesthesia is essential. You would use topical anesthetics and a methylcellulose gel for the lenses that you would use. Contact lenses would be helpful to use with a plano-convex optical button. So either the Abraham iridotomy lens or the WISE lens. Now what these buttons do is that they magnify the iris structure, so you're able to visualize crypts or areas of thinning that you want to target. They also minimize corneal burns. They act like a heat sink where it absorbs the heat energy away from the cornea. Also, it causes more of a convergence of the rays, the laser beams towards the iris rather than away from the cornea. It also helps keep the eye open and fixate the eye. The site that you select is usually between the middle third and the peripheral third of the iris. You really don't want to go too far off peripherally because you won't be able post-op to visualize the patency of your peripheral iridotomy. And also, you don't really, usually when you go very far off peripherally, you have an arcus senilis or corneal haze that can really blunt the response of your LPI. Now, position-wise, traditionally, we've been placing it under the upper eyelid, especially in the supranasal location to avoid the macula. So it's either 1 o'clock in the right eye and 11 o'clock in the left eye. However, there have been talks about risk of dysphotopsia, where they think that the fully covered ones, and that's what traditionally has been thought, that if it's fully covered under the upper eyelid, you have less chance of dysphotopsia or optical aberrations than the partially exposed ones or the fully exposed ones. But there are two prospective randomized control trials that were done recently by Vera et al. In 2014 that looked at temporal placement versus superior placement, and they found that temporal placement is less likely to cause dysphotopsia than the superior placement. However, Srinivasan in 2018 and his colleagues compared superior versus nasal versus temporal, and they found no difference in dysphotopsia regardless of location. I tend to avoid the lid margin at all costs. I usually like to go either nasal or temporal, but definitely I think the superior approach is a bit difficult to access, in my opinion. So there's no single set of laser parameters that is appropriate for all types of irides or for all surgeons. They need to be adjusted according to the intraoperative response or the iris of the patient. So typically, if you want to use the ND-YAG laser, you would use the parameters on the right-hand side. If you would use the argon laser, you would use like a two-step technique, which is on the left-hand side, where you have preparatory burns and then penetrating burns with those parameters. Those are textbook parameters of what you would use. However, I find in our eyes, in the GCC at least, and where I come from, the irises are very thick. And so it's beneficial to use a sequential laser, in my opinion, where you pre-treat the eye with argon, and then you use an ND-YAG. So what I do is actually thin the iris and char it with 50 shots of 0.1 seconds, 100 microns of 650 milliwatts, and then I follow it by another 50 shots, and I go down on the spot size to really get concentrated thinness centrally, and then I easily perforate with the ND-YAG laser, even using 3.5 millijoules on the ND-YAG, and I find that very useful in our eyes. The endpoint is really having 200 to 500 microns of diameter of the opening. Post-operatively, you'd instill a drop of iopidine, you'll give them topical steroids for a week, and you'll check the IOP an hour after the procedure. You bring them back to visualize the patency of the iridotomy, and usually people will say, oh, doctor, it transilluminates, so the PI is patent. That does not mean that it's patent. Transillumination can be patent even with strands of stroma that was just disrupted. So transillumination does not equal patency. The way to really evaluate patency is direct visualization, where you see the black hole within the opening, or even seeing zonules or a lens capsule behind the opening. Typically, you repeat gonioscopy to see if there's any effects of your procedure. So the outcomes you'd expect, you decrease the risk of future attacks of angle closure by pupillary block. You decrease the IOP, especially in patients that don't have optic nerve damage or don't have a significant PAS. You'd also produce changes in the angle configuration, reducing the risk of primary angle closure glaucoma. The complications are various, although mild, but the most prominent of which is the IOP rise from baseline. Usually about a third of cases experience IOP spikes, so you need to take care on patients that already have compromised optic nerve function. Inflammation, cataracts, optical aberrations, as we mentioned earlier, corneal decompensation, iris-related issues such as hyphema, posterior synechiae, and so forth. Posterior segment issues, choroidal effusions can happen, retinal detachments, macular holes have been documented, recurrent hepatic eye disease, or even malignant glaucoma. So my take-home messages today, it is estimated that 5.3 million people will be blinded by PACG by 2020. So the burden of disease is high, and LPI definitely has a role in the treatment algorithm for primary angle closure, but exactly at what point does it benefit, that's still debated, and who should be treated. Will LPI prevent disease progression? These are questions that are still gone unanswered. Up to about a quarter of PACS, or occludable eyes, have angles that remain closed after laser peripheral iridotomy. We saw a talk about this earlier today, and that's because of non-pupillary block mechanisms such as plateau iris or lens vault. The major challenge here is to create a patent iridotomy with minimal laser energy to prevent all the complications we mentioned earlier. And thank you very much.